students, I am Dr. Harmeet Goel. Today I will be discussing the questions of FMG December 2020 recall. I will be discussing the questions with the images as well as the explanations. This is very important as what we are seeing the pattern as we are taking the classes in the PG as well as for FMG students. So what I realize is that the questions which are being asked in the NEET PG, okay, so similar pattern of some of the questions which has been asked in the FMG exam are similar. Does not mean, so the present scenario should be that whatever the question is being asked in the present exam, like for example a Leopold's maneuver is being asked, it is being asked in the AIMS PG as well as the NEET PG. Now it has been repeated in the FMGE exam. Similarly, the Turner syndrome, similarly the Asherman syndrome, and so on. So it does not mean the questions of the FMG are not important for the students who have been preparing for the NEET PG exam or who are been preparing for the INI CET exam. Like Leopold's maneuver I am seeing is been asked in all the three exams. NEET PG exam has been delayed. Okay, so as all of you are aware of the circumstances, but the FMG exam has been taken up on December 2020, 4th December. So the questions are going to be important and many questions have been asked in the OBS and Gynae. So the students who are preparing for the NEET PG exam, just go through the questions. It is really going to be helpful for your preparation. It will be a quick revision for you also. So I'm just sharing my screen. So I'm discussing the December FMG 2020 OBS Gynae recall. Many questions have been asked and many of my students have sent me the questions. Accordingly, I have just prepared this and I was just trying to collect as many questions as I can. Of course, some of the questions which I have not added, they were very incomplete and the four options was not provided to me. So uh, around 40 questions have been asked in OBS Gynae, maybe more, because some of the questions I am still collecting. If I have been able to collect an adequate number of the questions, I will release part 2. So the students who are writing the NEET PG exam also, this video is going to be important for them, apart from the students who are going to give the FMG exam. And those who want to cross-check their answers, they can also go through this video. So there was a lot of requests from the students. They had been sending messages to me, just please release this video. So I'm releasing this. Okay. So identify the image. I think clearly everybody can identify whether the question was asked in very straight format or the question has been asked identify the image that has not been clear. So every student who has been sending me the images or the questions, they have told me an image of Turner syndrome was asked. Okay. So usually they give in the question that a young girl presents with primary amenorrhea. Young girl presents with primary amenorrhea. On examination, the breast development is absent and identify the image. So most important cause of primary amenorrhea is ovarian dysgenesis. Ovarian dysgenesis, that means there is streak gonads or streak ovaries. Okay, streak gonads or streak ovaries. During the intrauterine life, the oogonia get lost near about 20 weeks of pregnancy, where oogonia has to be maximum. This time the depletion occurs, so there is a ovarian deficiency at the time of the puberty. There is no ovulation, there is no estrogen. Okay, and many times a question has been asked on the karyotype. So karyotype of Turner syndrome is 45XO. Of course, in the image, the clear-cut stigmata is being visible. The stigmata, that is, we say the height you cannot make out, but you can see that there is congenital webbing of neck. Again and again, the question has been asked on the Turner syndrome. Okay, can you see there is increasing the carrying angle? This is cubitus valgus deformity. And in these patients, there is a congenital heart disease. The most common type of congenital heart disease seen in Turner syndrome is bicuspid aortic. Well, if that's not given, then you mark your answer as coarctation of aorta. There is low posterior hairline, low posterior hairline, and there is low set ears. So it is primary amenorrhea, infertility, shield-like chest, absent breast development, cubitus valgus deformity, congenital webbing of neck. There is short fourth metatarsal. Okay, so in these patients, the treatment is basically the treatment you have to give is estrogen and you add progesterone. Okay, so these patients are prone for osteoporosis. These patients are prone for autoimmune thyroiditis and diabetes later in life. These patients are also prone for ovarian tumors. The most common ovarian tumor in them is gonadoblastoma or dysgerminoma. Gonadoblastoma or dysgerminoma. Okay, so they have estrogen deficiency, and the type of ovarian tumor that can occur is gonadoblastoma, most common, or there is dysgerminoma. These patients have skeletal problems like scoliosis. These patients have the renal problems. The renal anomaly is horseshoe kidney, horseshoe shaped kidney. Okay, so this you have to remember karyotype 45XO, most important cause for primary amenorrhea. It is ovarian dysgenesis. There is streak gonads. Oogonia get lost in the intrauterine life. Karyotype is 45XO. So the lost X chromosome is derived from the father. The mother side one X chromosome is present in them. There is non-disjunction of the X chromosome in them. Okay, so short fourth metatarsal, congenital heart disease, bicuspid aortic valve, that's not given, coarctation of aorta, congenital webbing of neck, cubitus valgus deformity, and low posterior hairline, low set ears. So this is very well, you can identify it to be a case of Turner syndrome. Next, important question which was asked is 14-year-old girl present with cyclical pain abdomen. She has not yet attained menarche. Identify the image. So young girl, cyclical pain abdomen and no menarche. Cyclical pain abdomen means ovaries are present in them. Okay. So menarche has not started. If you do the examination in this female, breast is present, axillary pubic hair will be present, and the history is cyclical pain abdomen without external bleeding. So this is a case of cryptomenorrhea. Cryptomenorrhea means hypothalamus, pituitary, ovary, uterus, the whole axis is normal. Okay, the whole axis is normal. Okay, endometrial lining has been formed, endometrial lining has been shedding. Okay, but there is defect at the outflow tract. Okay, so the most important cause for cryptomenorrhea is imperforate hymen. Another cause can be transverse vaginal septum. So the imperforate hymen is usually the most common cause for congenital cryptomenorrhea. Cryptomenorrhea can be acquired when she's having periods and now it has stopped. If there is history of any conization being done or there is any amputation of the cervix has been done, that is Manchester operation, okay, then that can lead to the like acquired cryptomenorrhea. Okay, so in this case, this is clear cut an image of imperforate hymen, imperforate hymen, and the treatment is cruciate incision and drainage. Cruciate incision and drainage. So an ultrasound should be done, and in this case, if she's presenting with clinically, you do per rectal examination, uterus is present in them. So there's a bluish membrane which is bulging. So you give a cruciate incision and drain this imperforate hymen. So the next important question is definitely always there is a question on twins. Okay, so there is always a question on the twins, whether they are asking straight or they are asking an image based. So they have asked identify the type of twins from this. Although this, when I have taken the image, this was, not been given in the exam. This was not in the image in the exam. Okay, so they have just given the image and they have asked identify the what is the type of twins. So is it diamniotic, dichorionic, diamniotic, monochorionic, monoamniotic, monochorionic, or Diamese twins? Okay, you see there are two separate amnion. Okay, and there is a two separate placenta in them. Okay, two separate placenta. So it is diamniotic, dichorionic type of twins. Okay, usually the twins are of two types. The the dizygotic and monozygotic. This you know that 80% of the twins are dizygotic and 20% of the twins are monozygotic. Dizygotic twins, they are non-identical. They are biniovular twins. Biniovular twins. That means two ova are fertilized by two different sperms released in the same cycle, and they are being fertilized by single act of coitus. Single act of coitus. So dizygotic twins. Dizygotic twins are always diamniotic, dichorionic. Okay, two amnion and two chorion. So important point to differentiate the diamniotic dichorionic, that is dizygotic, from that of monozygotic. Here their intervening membrane is of 4 layers and it is more than 2 mm. So they have 2 amnion and 2 chorion, and the chances of survival in the dizygotic twins is much better, or dichorionic twins is much better than the monochorionic twins. Their membranes on the ultrasound shows a twin peak sign, which is also called as lambda sign. Twin peak sign or lambda sign. That means there is two amnion and there is an intervening chorionic tissue. So that gives 4 layers. Okay. So just remember, twin peak sign is seen in dichorionic twins. That is a type of dizygotic twins. And the intervening membrane is 4 layers, 2 amnion and 2 chorion, and it is more than 2 mm. So the chances of survival is better because they have a separate placenta. Whereas monozygotic twins are uniovular twins. They are maternal twins and they are identical twins. Okay, it depends. The division of the fertilized ovum occurs within 72 hours. The twins will be diamniotic, dichorionic. If it is between 4th to 8th day, then it is diamniotic, monochorionic. If the division is occurring after 8th day of fertilization, it will be monoamniotic, monochorionic. And if it is occurring after 13th day, it is Siamese twins, or it will be formed as conjoined twins, Siamese twins or conjoined twins. Okay, so the most common variety among all of them will be diamniotic monochorionic, but overall the most common variety of twins is diamniotic dichorionic because that is what dizygotic incidence is high. So among the monozygotic twins, the most common variety is diamniotic and monochorionic. The difference between monozygotic and dizygotic twins here it will be of two membranes. The intervening tissue in them contains two layers only amnion. There is no intervening chorion tissue. So you can see in this case the identical and the non-identical twins. So I will be able to explain it better with this. This is a monozygotic twin which is identical, and this is dizygotic twins. Can you see this is one layer, this is second layer, and this intervening chorion is two layers. So membrane is four layers and they have a two separate placenta. So chances of survival is better. So there is intervening chorion tissue. This on ultrasound will give you a picture of twin peak sign or lambda sign. Whereas monozygotic twins, it is containing two layers of two amnion only. Okay, two amnion only. So the dizygotic, the chances of survival is better. Okay, this is the four types of monozygotic twins: diamniotic, dichorionic. If the cleavage occurs after fourth and eighth day, diamniotic, monochorionic, that there is a single placenta which is being shed. In this case, if cleavage occurs after eighth day, then it is monoamniotic, monochorionic, that is there is a single placenta which is being shared. So there is chance for twin transfusion syndrome in them, and mortality is high. If it is division is occurring after 2 weeks of fertilization, it is conjoined twins, they may be sharing some organ or the tissue of the body. So the maximum perinatal mortality is seen in conjoined twins. Next question: absolute contraindication of this image. This image is copper T 380A, which is a government supply IUCD. It is the longest acting IUCD. It is applied free of cost in all the government sectors. Effective period is 10 years because the vertical stem contains copper and the horizontal arms contain copper. So more copper will be effective for many more years. And if you see the failure rate, it is 0.6 per 100 women year. So the absolute contraindication of IUCD is always PID, pelvic inflammatory disease. Nulliparity, nowadays the frameless IUCD is being applied. Hypertension may be a contraindication to OCPs, but it is not a contraindication to the use of IUCD. Whereas tuberculosis is a contraindication, PID is a contraindication, distorted uterine cavity is a contraindication. In anemia, you can apply the Mirena. That is a hormone releasing IUCD. So let us just see what are the absolute contraindications of IUCD. Absolute contraindication of IUCD includes the suspected pregnancy, acute PID or STD, HIV positive. So acute PID, again and again, they are asking in the question. So acute PID, again and again, they are asking in the question. Okay, so it is acute PID, suspected pregnancy, the STD, HIV positive, choriocarcinoma, that is trophoblastic tumor, then suspected genital tract cancer, suspected genital tract cancer, undiagnosed uterine bleeding. If there is any component of sepsis, it is contraindicated. Then severely distorted uterine cavity, then previous classical cesarean scar. So these are some of the important contraindications to the IUCD. In Mirena, even the breast cancer is a contraindication. Now, what are the cancers where you will not apply IUCD? That is important for you to know. If there is cancer cervix, IUCD is contraindicated. Endometrial cancer, any gestational trophoblastic tumors, these are the three main absolute contraindications to the IUCD insertion. Now, why PID or even the tuberculosis is a contraindication? Because the PID means STD and there is an ascending infection. COPD or IUCD is a foreign body which spreads STD, and the chance of intrauterine pregnancy may be prevented, but it will increase the chance for ectopic pregnancy, because when you are applying IUCD, it does not ban the entry of sperms. It does not suppresses the ovulation. So the fertilization is occurring. But the mechanism of action of IUCDs prevents implantation, but simultaneously no protection against ectopic pregnancy. So number one, if there is STD, PID, sepsis, HIV, there is a spread of infection. Number two, the chance of ectopic pregnancy will be increased as the cilia might be damaged by the infection. Okay, so the fertilized ovum will stay there. None of the IUCDs are usually giving protection against ectopic pregnancy, although the article says Mirena is somewhere better than copper releasing IUCDs. So undiagnosed uterine bleeding, because copper-T, the most common complication is bleeding, and if there is undiagnosed bleeding, you will not be able to rule out any uterine or cervical pathology which is causing bleeding. You might be thinking it is copper-T which is causing bleeding, but actually there may be some underlying pathology like endometrial hyperplasia, endometrial polyp, endometrial cancer, or the cervix cancer, which may be missed out. Okay. Next, a woman presented in the gyneopedy with secondary amenorrhea. There is history of curettage. Secondary amenorrhea. Okay. And there is history of curettage being done for the abortion. So they are giving you a clear-cut hint. FSH is 7 milli international units per ml. I think some more information would have been given, but the students who have sent me this question, somewhat, like incomplete history they have provided, because it might have been what type of abortion was there when the curettage was done. Usually it may be inevitable or missed abortion, or it is incomplete abortion. Number two, the FSH levels are been given. Normally, the FSH levels are between 5 to 20 milli international units per ml. So this FSH is normal. Okay, if there is a pituitary failure, the FSH will be less than 5. If it is ovarian failure, the FSH will be elevated more than 40 milli international units per ml. And of course, ovarian failure has no relation with the curettage. Okay, so this history, similar question has been asked in one of the AIMS PG exam, and it has been asked in NEET PG exam. So similar pattern they have asked this time for the FMG exam. That is why it is important. So any questions which has been recently asked in any of the exam, every student who is writing either the FMG or the NEET PG or now INI CET exam, questions are more somewhat similar Only some format of the question is been the one which they are varying. Okay. So history of curettage. So what is Asherman syndrome? Asherman syndrome, number one, it is the most important cause of secondary amenorrhea, and there is formation of synechiae or adhesions between the anterior and posterior uterine wall. So the history of curettage, if there is MTP or there is DNC being done or there is a postpartum curettage being done, then vigorous curettage leads to adhesion. So the clinical features may be oligomenorrhea, secondary amenorrhea, or hypomenorrhea, or it is infertility. So most common will be the hypomenorrhea. So there is history of curettage they are giving you a clue. It is secondary amenorrhea and FSH levels are normal. Okay. Even if you do give a progesterone, withdrawal bleeding will be absent. If you add estrogen and progesterone, then also withdrawal bleeding will be absent because the endometrial cavity is being distorted. So management will be you confirm this diagnosis by HSG where you see irregular filling defects, and then you switch over to the gold standard investigation, which is hysteroscopy. Because on hysteroscopy, it will be confirming your diagnostic as well as therapeutically you can break the adhesions. So all this Asherman syndrome, Turner syndrome, the twins topic, all this image-based question and the clinical questions I had been teaching in my classes. So students are very much satisfied with the classes and the one-day revision program which I have taken because many questions straight away has been asked from that. Okay, so this is the HSG image showing Asherman syndrome. This is irregular filling defect, and this is hysteroscopy image which is showing adhesions. So the management is hysteroscopic guided adhesiolysis. Break the adhesions. So hysteroscopy is the gold standard investigation if you find any uterine pathology just like this. Now next question. This has been asked in this INI CET, which is a combined exam for AIMS, for JIPMER, for PGI and NIMHANS. Similar question has been asked in previous aims. Similar question has been asked in NEET PG. Now a similar maneuver, Leopold's maneuver, is been asked in FMGE exam. So that is why the questions are the same. Sometimes they ask Leopold's maneuver 2, Leopold's maneuver 3. Now what is a Leopold's maneuver? Leopold's maneuver is when you do per abdomen examination, you apply first grip. First grip is called as the fundal grip, where in the fundal grip you feel soft fetal parts, which is non-ballotable, suggestive of, like the limbs, or it is hard globular part suggestive of head. The second grip is the lateral grip. Lateral grip, you feel the back of the baby. In this INI exam, the second grip was asked. The third grip is called as the pollic grip. In the pollic grip, you have idea about the presentation. If head is presenting, you say cephalic. If feet is presenting, you say podalic presentation, where the hard globular part, all these three grips are applied while you're standing on the right side of the patient and you are facing the patient. Whereas the fourth grip is called as the pelvic grip. Fourth is to check for the engagement. When your fingers are converging, that means the head is not engaged. If the fingers are diverging, that means head is engaged. So this is a Leopold's maneuver to check for the lie and presentation. Leopold's maneuver to check for the lie and presentation. This even the images PPT or the PDF I shared to my students. This image I have explained in the one day revision, in my regular classes, even for the quick revision, I have made an image based slide which I have shared to the students. So that was really helpful. And the teacher is always satisfied when from their teaching the students are getting benefited. Okay, so this grip is the Leopold's third grip, which I have just explained. Next question. Identify the image. So this is a clear-cut image of the polycystic ovarian disease, which has been asked in previously 2014 FMG exam as well as the DNB PG exam. So PCOD always, just remember, it is the most common cause of hirsutism in a young girl. So you remember the Rotterdam criteria for the PCOD. There is hyperandrogenism. There is hyperandrogenism, that is the lab finding or the clinical finding. Then there is an ovulation leading to menstrual disturbance like oligomenorrhea or secondary amenorrhea, and ultrasound showing polycystic ovaries. Ultrasound showing polycystic ovaries. And Rotterdam says out of the three, two criteria have to be present. So most of the time the androgens is high and there is an ovulation. This is the important criteria. So even the ultrasound is important. Only out of the three, if two criteria are present, you can make the diagnosis of polycystic ovarian disease. So there are more than 10 to 12 cysts in the ovaries and the diameter is 2 to 9 millimeters, or you can say the ovarian volume is more than 10 ml. Okay, so that is what is a Rotterdam criteria. So many times in 2019 FMG they have asked the most common cause of hirsutism is PCOD, provided that other causes of hirsutism you have ruled out. Other causes of hirsutism includes, it is congenital adrenal hyperplasia, it is adrenal tumor, it is androgen secreting ovarian tumor, it is Cushing's. So all these have to be ruled out by exclusion, and the most common among them is polycystic ovarian disease. So there is facial hair, that is hirsutism. Then there is sometimes many cases obesity, many cases presents with menstrual disturbance, many cases presents with infertility. In the infertility, one more thing you remember, there is in infertility, you are giving an ovulation induction agents. Ovulation induction agent, previously we were giving clomiphene citrate, now letrozole, the results are better than clomiphene citrate. Letrozole is aromatase enzyme inhibitor. Aromatase enzyme inhibitor. So the less side effects and it is giving more promising results. Previously, letrozole was not available in India. Now it has been available. The clomiphene for so many years has been a drug, first line drug for infertility cases. Now letrozole is being preferred based upon the clinical trials. Clomiphene citrate is an anti-estrogen. Of course, letrozole also acts on the principle of anti-estrogen only. So many times a question has been asked in the PG, if the patient is obese and she has PCOD, she has menstrual disturbance, what is the first step you will do? The first step in managing the patients is lifestyle modification. Lifestyle modification. That is, she has to reduce weight, she has to consume more of the vitamins and minerals and protein rich diet, she has to go for brisk walking, she has to do exercise. So by suppressing this will help in suppressing the androgen levels, automatically the hormonal imbalance will get corrected. So this is clear cut about PCOD. Next image they have asked, some history might have been given or a direct image has been asked. Usually they give a clear-cut history. History which is suggestive of molar pregnancy. Whether there is a patient presenting with amenorrhea, she has history of grape-like vesicles discharged from the parvaginum, or there is beta HCG which has been shown elevated, and ultrasound has been done. Of course, the investigation of choice for a molar pregnancy is ultrasound, where they show a clear cut snowstorm appearance. So this was an image of molar pregnancy. In molar pregnancy, many times they ask the differentiating point between a complete mole or the partial mole. So students who are preparing for the NEET PG, so just pay attention that there may be a question on the clinical history with the image, or there may be a question on the point to differentiate between complete mole or the partial mole. The best one to differentiate is the karyotype. Here it is diploid, here it is triploid. 90% cases it is 46XX, 10% cases it is 46XY, here it is 69XXX or 69XXY. Okay, just remember the abnormal chromosomes are paternal in origin. This question has been asked in FMG 2019, that what is the karyotype, and the abnormal chromosomes are maternal in origin or paternal in origin, so it is derived from the father. What happens? This is ovum and this gets fertilized by a sperm. Normally, the sperm is 23X or 23Y and ovum is 23X. But in this case, there is an empty ovum where there is no chromosomes. So it gets fertilized by a sperm where the chromosome of the sperm is 23X. After fertilization, the chromosome of the sperms duplicates upon itself. Okay, so some fertilization has taken place, so something will be formed. So fetus will not be formed. Here there is grape-like vesicles. So 90% cases it is 46XX. So the abnormal chromosomes are derived from the father. So what happens in 10% of the cases? In 10% of the cases, the empty ovum, that means it is not containing any chromosomes, is fertilized by two sperms, 23X and 23Y. So again, there is an abnormality, 46XY, and abnormal chromosomes are derived from the father. Whereas in case of partial mole, there is normal happy ovum, that is ovum, which is containing 23X chromosomes, but unfortunately it gets fertilized by two sperms. So karyotyping is triploid. Okay, so what happens is, because one ovum and the sperm chromosomes are normal, so fetus is formed. An extra set of chromosomes, so the vesicles are formed. Usually they land up in missed abortion. So another point to differentiate is complete mole, no fetal tissue present, only grape-like vesicles, whereas partial mole, the fetal tissue is present. So this is clear-cut snowstorm appearance and molar pregnancy. Again, there was another image which was asked, identify the image. This is an image of HSG, hysterosalpingography, where a radio opaque dye is put in the uterus, and you can see uterus contour almost normal looking, but in the tube there is distal end of the tube is blocked. So it is bilateral distal tubal block, a presentation of PID. So this type of presentation where distended fimbrial end, this is called as hydrosalpinx. Hydrosalpinx. So all this is a type of presentation, that is PID, pelvic inflammatory disease. In this case, this HSG has been done and it is showing the fimbrial end blocked. So ideally in this case, you can go for a, when there is a distal tubal block, you can go for a laparoscopy, and from laparoscopy, a fimbrioplasty can be done. A fimbrioscope can be put to try, but usually the best treatment for a distal tubal block in modern times is IVF, in vitro fertilization. Now next, most common cause for cancer cervix, I think everybody knows, human papilloma virus 1618. So this is a clear-cut case, straightforward question. What is the most common type of cancer? Is squamous cell carcinoma. the next in the NEET PG exam or the subsequent exam, they can ask about the vaccine. Again, vaccine is Cervarix or the vaccine is Gardasil. Gardasil is a quadrivalent vaccine, that is HPV 6, 11, 16, 18. Cervarix is bivalent vaccine, which is HPV 16 and 18. And the age group for vaccination is 9 to 26 years. Ideally, the boys and the girls should all be vaccinated before the sexual activity starts. Why the boys and why the girls? What are the cancers caused by HPV? Cancers caused by HPV. Cancer cervix, it is proven, that is HPV 16 and 18. Then it is also been implicated in vulval cancer, in the boys, the penile cancer, the anorectal cancer, the oropharynx cancer. So ideally the boys should also be vaccinated. Nowadays there is Gardasil 9 vaccine has been available, that is nonavalent vaccine. So you should be knowing what are the strains in nonavalent. So it is HPV 6 and 11, which is causing genital warts. In 2020 August, they have given an image-based question on the genital warts and they have asked the cause. So it is 6 and 11. Then there is 16, 18, 31, 33, which is causing cancer cervix. Then there is 45, 52, and 58. This is what is a nonavalent vaccine. HPV 6, 11, 16, 18, 31, 33, 45, 52, and 58. And the screening test for cancer cervix, just remember, is the pap smear. According to WHO, first pap smear is to be done at what year? Is 21 years of age in a sexually active female. Then every 3 yearly it is done till the age of the female is 30 years, and then it is to be done till 60 to 65 years and then stop. So pap smear should be done between 21 to 65 years of age. That is a screening test. Next question. 12 weeks of pregnant lady with a history of Down syndrome baby in the previous pregnancy. What will be the confirmatory test? 12 weeks they have given you. So you know the blood markers are done in the first trimester and in the second trimester. In the first trimester, it is the beta HCG and it is Papa. Beta HCG is elevated, Papa is down, and in the second trimester, it is triple test. Triple test includes the beta HCG, the alpha fetoproteins, and serum estriol. HCG rises, alpha fetoprotein decreases, and the estriol decreases. Okay, so it is done between 15 to 18 weeks. This is the screening. And in the quadruple test for Downs, all these three markers are there. One new marker is being added, that is inhibin A, which is being elevated. So that is also done around 16 to 18 weeks. So 12 weeks pregnancy where there is a history of Down syndrome, ideally this should have come for a preconceptional counseling, and in the first trimester the blood marker should have been done. If the blood markers are positive, then the next step is around 10 to 12 weeks. The best is confirmatory chorionic villus sampling, and the sample is taken for karyotype. So first of all, in the first trimester, the blood markers plus ultrasound for a nuchal translucency should be done. In the second trimester, triple test plus nuchal fold thickness, that is second trimester ultrasound, the soft tissue markers should be done. Okay, so here, since it is 12 weeks of pregnancy, so I would like to go for a confirmatory test, that is chorionic villus sampling. Okay, that is a transcervical catheter is being introduced and the sample is taken from chorion frondosum and a karyotyping is being done. In the second trimester, confirmatory is amniocentesis. Next question. 11 weeks of pregnancy, period of gestation is 11 weeks, and the lady doesn't want suction evacuation. What else can be prescribed? She is 11 weeks pregnant and she does not want any surgical procedure. Neither she should have been taken up for suction evacuation, but she doesn't want. So what will you give? Mifepristone plus misoprostol, that is by oral tablets, abortion is being conducted, but the limit is less than 9 weeks. Okay. So mifepristone 200 milligram oral followed by misoprostol 800 microgram vaginal is been given. But this has crossed the limit. Mifepristone alone is not used, so misoprostol intravaginal tablets can be used 400 to 800 micrograms intravaginal. But this, the patient has to be admitted. You cannot allow her to be at home and she should be doing insertion. Insertion is to be done by the doctor, and 400 to 800 micrograms of misoprostol, which is prostaglandin E1, can be used, and it is repeated every 3 hourly till she aborts. According to the question provided to me by the students, the best answer I will mark is misoprostol. So just remember prostaglandin E1, misoprostol. What are the important uses? Important uses is MTP, first trimester, second trimester, for abortion, like missed abortion or inevitable abortion, usually missed abortion. Then it is useful in postpartum hemorrhage. Then it is been used for induction of labor. So what is the dosage? Just remember, so this is important for the NEET PG students also. So MTP first trimester, second trimester, the dose is 400 to 800 microgram vaginal tablets in the repeated doses. For abortion, it is same. For PPH, it is sublingual dose, which is nowadays preferred 800 micrograms. Then it is preferred per rectal dose 1000 micrograms. Then it is oral dose, which is 600 micrograms. So sublingual is being preferred if it is atonic PPH. Then for induction of labor, 25 micrograms vaginal dose. So the prostaglandin E1, which is misoprostol, is used for MTP. It is used for abortion, postpartum hemorrhage, and induction of labor. Okay, so here I will mark the answer as misoprostol. A woman after hysterectomy has developed distended abdomen and there is an electrolyte imbalance. So most common cause for distension abdomen after the surgery is usually paralytic ileus, because while we are doing hysterectomy or we are doing a cesarean section, there is a gut handling that can lead to the paralytic ileus. So when you do observe this patient in the post-operative period, she presents with nausea, vomiting, there is abdominal discomfort, there is abdominal distension, and there is no passage of flatus. While you are auscultating, there is no vowel sound even after the appropriate treatment. So you make the diagnosis of a paralytic ileus, but you have to rule out any intestinal obstruction from them. The important point to differentiate it from the intestinal obstruction is that the vowel sounds are present in intestinal obstruction and there is pain to the patient. Okay, so important cause for paralytic ileus is electrolyte imbalance, that is hypokalemia. Okay, so in this patient, the management is you keep the patient nil orally and you put her on IV fluids. IV fluids, good fluid is a ringer lactate, or if you have to substitute potassium, you can give her pot chlor later on. But since the patient is nil orally, so this is usually being suspended for some time. Keep the patient nil orally, give only IV fluids, and usually the paralytic ileus is self-limiting and no treatment is needed most of the time. Okay, so paralytic ileus occurs most of the time abdominal operations because so much of the gut handling is being done. Among the proposed mechanism, there is a dysmotility by the surgical stress-induced sympathetic reflexes, inflammatory responses or mediators, sometimes to the anesthetic or analgesic effects. There is an inhibitory effect onto the intestinal motility. So just an observation, nil per orally, IV fluids, and just an observation. So it will usually gets resolved of its own. Okay. So it has got a self-limiting course. So correct the electrolytes. Now next, a 23-year-old lady presents with complaints of post-coital bleeding. On per speculum examination, there is bleeds on touch. Young patient, okay, very young patient. Different set of students have given me different statement of the questions. So I'm discussing both. Young patient, post-coital bleeding. So you are a better judge. Which type of image was been given? You can tell us. Okay, if the exact image is been provided, if the age of the patient is young and it is a post-coital bleeding, so keeping the mind the age of the patient young, cervical polyp. If this an image was given, this is a cervical polyp, okay, which bleeds on touch. There is a history of post-coital bleeding, so cervical polyp. Okay, another set of students have sent me a question. 55-year-old female has presented with post-coital bleeding. Post-coital bleeding is a very specific symptom of cancer cervix, that is squamous cell carcinoma. Okay, squamous cell carcinoma. The most common presentation of cancer cervix is irregular vaginal bleeding. Since the incidence of cancer cervix is high in our country, so first diagnosis we keep it is the cancer cervix. If age is 55, post-coital bleeding history is there, and image given in the exam is just like this. So you are a better judge. You can tell us whether it is young patient and this image was given. So the answer is cervical polyp. If the age was 55 and this image was given, then the answer is cancer cervix. This looks like cauliflower like growth. It is squamous cell carcinoma. This bleeds on touch. There is friability. There is induration. These are the features, signs, and symptoms of the cancer cervix. There is dirty vaginal discharge. So these are the symptoms and signs of cancer cervix. If young patient and this image, then I will mark cervical polyp. If 55 and this image was given, so I will mark cancer cervix. Okay, so sometimes the polyp can be small or large. So you are a better judge which type of image was given in your exam. Okay, so next question. 25-year-old girl came with a history of sexual assault. She is asking for an emergency contraception within 8 hours of sexual assault. She is on 13th day of her menstrual cycle. What is a suitable contraceptive for her? Okay, so most probably it would have been an unmarried girl, or if it is a married patient, so the emergency contraception, she has come within 72 hours. So a hormonal emergency contraception can be provided to her. If she had come more than 5 days, then IUCD insertion. In the hormonal contraception, there is levonorgestrel pill where 1.5 milligrams single dose. Another is within 72 hours I'm talking about. There is OCPs, which is low dose pills, or there is high dose pills. So 4 tablets after a gap of 12 hours, 4 tablets. Another emergency contraception is RU486, and the dose, although in Shaw's it's given 10 milligrams, in other books it is given 600 milligrams. So a dose can be given that is hormonal. In the if she's coming after fifth day, then a copper T insertion can be done. Ideally, the best for emergency contraception is the copper T because it prevents the implantation. But if it is unmarried, then copper T insertion is almost ruled out. Then you have to provide the hormonal. Another within 5 days you can give nowadays is Ulipristal. Ulipristal is selective progesterone receptor modulator, and it can be given within 5 days, and it has shown a promising results. Okay, the dose is 30 milligram for 5 days. Okay, so depending upon this situation, if it is unmarried, then I can prescribe the levonorgestrel to her. If it is married and she's willing, copper T insertion can be done, or a ulipristal or OCPs can be given. Now, if this is the history, so I just missed out the question here. There was some question which was asked, yes, in the same, I think. So in this situation, it is levonorgestrel pill which I would like to give her. DMPA injection, I'm not in favor. It is not an emergency contraception. OCP for next cycle, suppose if the fertilization has occurred, so she will get pregnant. Misoprostol is not at all emergency contraception. So I think the options given to us, so I will give levonorgestrel 1.5 milligram single dose to her. It is not grams, sorry. It is in milligrams. So I think while I was typing the question wrongly, I have typed. So it is milligram. Now, next question, 25-year-old female after 6 weeks of delivery came just for routine checkup asking for contraception. 6 weeks after delivery, she has come and asking for a contraception. Are you going to give minipill, DMPA, OCPs or lactation? Lactation, we don't, believe in that. Although lactational amenorrhea, in the books it is written for the 10 weeks it gives contraception because lactation suppresses the release of FSH-LH, but that's not been done. So ideally there should be an IUCD. OCPs is relatively contraindicated in a lactating mother because estrogen suppresses the breast milk. So in the lactating female, since she has come after the delivery and it is lactating mother, I will give minipill in this question. Otherwise, an IUCD insertion can be done if she wants a spacing, otherwise minipill. Next, 14-year-old girl came with excessive bleeding. She has started with menarche, excessive bleeding. Of course, the history provided to me is incomplete. Okay. Are you going to prescribe OCPs, progesterone, minipill, injectable? Minipill and injectable is out of my list. Okay. At the time of menarche, what happens? Many times the cycles are anovulatory. So estrogen is very high in them. So estrogen, there is a very thick proliferative endometrium. Okay. So in this case, a hemostatic, the investigation should be done to rule out any clotting factor deficiency. So important investigation is for TB, complete blood count including the platelets, coagulation profile, the thyroid function tests, all should be done. And sometimes if you're suspecting anything suspicious, then an ultrasound should be done. Okay, so all this investigation should be done. Hemostatic injection, Trenexa MF can be given if to assess the hemoglobin. If she has lost so much of blood, a blood transfusion or hematinic should be prescribed to stop the bleeding. I can start her on progesterone. Okay, and for some cycles, I can put the patient on progesterone. Next. Patient is in labor and the vaginal examination is 5 centimeters dilated, fully effaced. She is in which stage of labor? Usually most of the time, according to WHO partogram, it has been asked, the latent phase is taken up to the 4 centimeters and active stage starts from more than 4 centimeters. So in the WHO partogram, from the 4 centimeters, the alert line is being plotted and 4 hours right is an action line. So active labor we mean by from the 4 centimeters. Of course, the latent phase is not being plotted in the WHO modified partogram, but in the ACOG, the latent phase is taken till 5 centimeters and the active stage is from the 6 centimeters. This has been added in the latest textbook of Williams, but even in the AIMS PG exam, being asked till the WHO partogram is being asked, so 4 centimeters. So I would like to take this case, keeping in mind the active state, unless until ACOG is been given or the latest question is been asked. So remember, plotting or the active stage of the labor, we keep it in mind from the 4 centimeters onwards. So I would like to put this in active phase. Next, patient presented with 11 weeks of pregnancy and with the mild spotting per vaginum. Ultrasound shows gestation sac without a fetal pole. Ultrasound, the uterus size is normal. No gestation sac, but is it present in the uterus or what? Okay, so from the history, it is very, very incomplete question. Fetal pole, why there is no fetal pole? So is it if there was a gestation sac in the uterus and there is no fetal pole, that means it is either missed abortion or it is just blighted ovum. Okay, so from this incomplete history, and there is mild spotting, I would say missed abortion. Had it been a threatened abortion, there is a gestation sac in the uterus clearly written. And what about the cardiac activity? If the cardiac activity was present and the cervix was closed, so either I just want in the history what the cervix finding, whether it is closed, whether it is open, and what type of vaginal bleeding. If it is a brown color vaginal discharge, the size of the uterus is less than the period of gestation, then it is missed abortion. If the size of the uterus is equal to the period of gestation, cervix is closed, and the cardiac activity present, I would mark the answer as threatened abortion. If the cervix is open and the product of conception failed, but the size is same as that of the period of gestation, I will mark the answer as inevitable. If it is written, the patient is bleeding profusely and the cervix is open and the products are hanging out in vagina, so then I will mark incomplete abortion. So from this incomplete history, I will mark the answer as missed abortion. Next, 14 cc fetal material was detected on ultrasound, planned for evacuation, but the catheter goes in without any uterine resistance. That means while doing the MTP, okay, the uterus has been perforated and the cannula has gone inside. Okay, so no wait and watch. Okay, no mifepristone. Continue the procedure, no way. Immediate laparoscopy, and if needed, the laparotomy should be done and stitching of this perforation should be done. True conjugate means, true conjugate means the actual conjugate. That means we are asking the anatomical conjugate of the inlet. Okay, so sacral promontory to the lower border of symphysis pubis, upper border of symphysis pubis to sacral promontory, or from the posteriorly from symphysis pubis to the sacral promontory. So just remember this diagram I had been teaching in my classes. The inlet, inlet is from the symphysis pubis upper border to the S1 vertebra, that is symphysis, the sacral promontory. So the symphysis pubis cut section is divided into three parts. From the above, it is anatomical conjugate, which is called as true conjugate. From the upper border of symphysis pubis to the sacral promontory, it is 11 centimeters. From the midpoint of symphysis pubis to sacral promontory, it is obstetrical conjugate 10 centimeters. From the lower border of symphysis pubis to the sacral promontory, 12 centimeter, which is a diagonal conjugate. Clinically measured conjugate is the diagonal. So in this question, it is from the upper border of symphysis pubis to the sacral promontory. Next, 30-year-old female came for a regular checkup, found to be 6 by 6 centimeters ovarian cyst. What is your next step in management? Number one, the patient is in the reproductive age group. She's come for a regular checkup and incidentally you diagnose an ovarian cyst. Remember, if it is 7 centimeter and it is a unilocular cyst and the patient is just asymptomatic. Okay, so just an observation is required. Most of it is the functional cyst of the ovary. Functional cyst of the ovary. So reproductive age group, most of the time it is a functional cyst of the ovary, which can be a follicular cyst. Follicular cyst develops when there is follicles fail to rupture. The follicles fail to rupture. Okay. Then another cyst can be corpus luteum cyst. Corpus luteum cyst, which is when there is collection of the fluid in the corpus luteum. This usually also called as hemorrhagic cyst and it presents with pain. Third type of cyst is the theca luteal cyst. Theca luteal cyst develops when there is H. molar pregnancy or there is choriocarcinoma or there is twins or there is ovulation induction. Ovulation induction being given. So theca luteal cyst resolves when you give the treatment of this. Follicular cyst of the ovary usually resolves of its own. Usually it is painless or it just presents with pain. So just an observation is required. So in the follicular cyst of the ovary, usually it usually resolves. So just an observation is required. Okay, observation is required. If the cyst is persisting after 3 months on the examination and on the ultrasound, then you can prescribe her OCPs. If she is infertile, then you can give her ovulation induction. If the hemorrhagic cyst is big in size, then surgical intervention, then cyst resolving can be done or cyst aspiration can be done. If the patient is very symptomatic or the size is increasing, then laparoscopically it can be done. So in this case, I would like to keep the patient just for combined OCPs and follow-up. Cystectomy, oophorectomy, CA125, all this is not required. So just a combined OCPs and follow-up. Cyst will resolve. A patient underwent oral glucose tolerance test 27 weeks because oral GTT, the ideal time is 24 to 28 weeks to rule out gestational diabetes because it is developing at this time. This is most sensitive time. Her fasting glucose is 130 and 2 hours is more than 200. AFI is 14. What is your next step in management? Nowadays, there is a DIPSI criteria which has been followed. That is, you give a 75 grams of glucose and you check the blood sugar after 2 hours. Its value is cut off 140 milligram. Or there's a two-step criteria that is, like confirmatory test where you give 75 grams of glucose. You take a fasting 1 hour and 2 hours. Fasting should be less than 92. 1 hour should be less than 180 and this is 153. Or there is oral GTT which is been 3 hours with 100 grams of glucose. Fasting 1 hour, 2 hour, 3 hours. So less than 95, less than 180, less than 155, or less than 140. Whichever criteria you follow. Usually this and International Association of Diabetes in Pregnancy Study Group. This criteria is being followed. Nowadays, DIPSI for screening and International Association of Diabetes Study Group, that is Diabetes in Pregnancy Study Group. This criteria is being followed. Whichever you take, this is blood sugar raised. So admit her and start insulin and check at 34 weeks. Repeat oral GTT, no need to repeat. Start insulin and do monthly checkups. No. We will just admit her and start the insulin. Why? You will admit her and you will just do a fasting blood sugar, then you do before breakfast and after breakfast, pre-meal and post-meal, before lunch, after lunch, before dinner, after dinner, and sometimes around 2 a.m. it is been repeated. Okay, so at least 8 samples should be done to check what is the pattern, and accordingly you can start her on regular short acting insulin. Okay, and later on you can switch over to the mixtard, that is a combination of the two insulin, the short and the ultra short acting, or the lenti insulin. So diabetes is very very tricky management. If the blood sugars are high, the baby develops macrosomia. If the insulin dose is given more, the baby develops hypoglycemia. So insulin properly and blood sugar monitoring is very very important. So patient is being stabilized, and regular checkups has been done in these patients. So first of all, you admit and check the blood sugar levels pre-lunch, post-lunch, before breakfast, after breakfast, urine sugars, and complete profile. And an ultrasound should be done. Then she should be put over to the insulin and she should be taught to check her blood sugar. And she is advised to keep a glucometer, and she should be trained for the insulin, and she can herself adjust the dose. So a diabetic referral should be taken from the physician or a diabetologist, whichever is available. Accordingly, the adjustment can be done, and the regular checkups and the biophysical profile or NST, that is non-stress test, should be done later on at the regular intervals. Okay, next. Now identify what type of method is this. Okay, so here you can see there is something which has been inserted here. So this is basically hysteroscopic sterilization, although this is not been so much preferred because it is a permanent method and there is no chance of reversal. It will permanently damage the tube, and this looks like Assure to me. Assure is just like this, and this was one of the question being asked in AIMS PG, and they have asked in the FMG exam. So there is just a stainless steel coil which by the hysteroscopy is being inserted into the fallopian tube, and there is epithelialization takes place over this. So patient has to use additional method of contraception for 3 months. So it completely blocks the tube because there is an epithelialization which takes over. So if the patient wants reversal, there is no reversal possible. So hence it is not a preferred method. So this image is showing a hysteroscopic sterilization. There is another hysteroscopic sterilization which is Adiana. Again, Adiana, there is damaging the permanent of the tube and there is no chance for reversal. So which image was given? If this is given or this is given, that is a hysteroscopic sterilization. Now, most dependent part of the female in the sitting posture is always the pouch of Douglas. Pouch of Douglas between the uterus, uterus and the rectum. This is the most dependent part. So importance of this cul-de-sac or the pouch of Douglas is if a patient presents with amenorrhea, pain, bleeding, fainting, and it is a rupture ectopic pregnancy, you don't have time or the condition of the patient does not allow for you to get an ultrasound done, then a culdocentesis can be done as this is the most dependent part. A needle is being put in the pouch of Douglas and you can aspirate the blood. So the importance is culdocentesis. So most dependent part is the pouch of Douglas. A baby born to diabetic mother shows hypoglycemia after delivery. What was the reason is excess of insulin. So in diabetic patients, the baby born is usually the most common metabolic problem in these babies is hypoglycemia, because when the mother was having diabetes, the increased glucose was diverting to the fetus and fetal pancreas gets stimulated, released more of the insulin, and insulin causes quick utilization of the glucose and baby develops hypoglycemia. So that is why the blood sugar monitoring in the baby born to diabetic mother is very, very important in the nurseries. So this is one of the most important metabolic cause of convulsions in a newborn baby, hypoglycemia. Other important cause is hypocalcemia. Now, which of the following contraceptive is contraindicated in the postpartum period? That is just after delivery. OCPs, IUCDs, barrier injectables. The barrier can be given injectable. Combined OCPs are contraindicated because estrogen suppresses the breast milk. So I would like to mark the answer as oral contraceptive pills is contraindicated. Mini pill can be given. Next, a nulliparous female and infertile uterus is retroverted mass in the lower uterine cavity that is posterior fornix and there is tenderness. Nulliparous, infertility, tenderness. This is towards the straightaway diagnosis of endometriosis, retroverted uterus, clear-cut diagnosis. Laparoscopy is the gold standard. In the previous exam, they have asked a question, what is the gold standard investigation? In another exam, they have asked most common site for endometriosis, that is ovary, chocolate cyst of ovary. Then another exam, they have asked about the endometriosis, that is most common symptom of endometriosis. Remember, most common symptom of endometriosis is always congestive dysmenorrhea. Congestive dysmenorrhea. Classical presentation of patient is dysmenorrhea, menorrhagia, infertility. And if there is a finding tenderness in the pouch of Douglas, that is clicking towards the diagnosis. So the endometriosis is chocolate cyst ovary. There is bowel endometriosis. There is adhesion. So it is an important cause of infertility. Pouch of Douglas endometriosis, bowel endometriosis, distorted. So if there is mild endometriosis, the infertility treatment is clomiphene citrate. If there is moderate to severe endometriosis, best is IVF, in vitro fertilization. And the gold standard investigation in endometriosis is laparoscopy because it will be diagnostic as well as therapeutic. Next, which of the following drug is given to the mother who is just delivering a preterm baby? So there is preterm labor pains and lung maturation. So it is always a steroid, dexamethasone. If beta-methasone was written, you should have selected the beta-methasone. Okay. Magnesium sulfate acts as a tocolytic agent. Aspirin is useful in PIH patients. So here it is dexamethasone, which is the answer. Which intravenous anesthetic agent in the daycare can cause hallucinations? So it is ketamine. Daycare anesthesia, we prefer a drug for MTPs, DNC, and short procedures, that is IV propofol. Previously, they have asked a question on IV propofol. A preterm baby born has respiratory distress. A chest X-ray done showed. Chest X-ray done showed hyaline membrane disease, that is ground glass ground glass appearance, and treatment for hyaline membrane disease is surfactant through endotracheal route. Surfactant through endotracheal route. First meconium passed after birth is usually first 48 hours. The best answer is first 48 hours. Next, 45 days period of gestation. The best MTP, I would like to mark mifepristone followed by misoprostol, which can be given within 49 days of missed periods. Okay, so mifepristone followed by misoprostol. Semen analysis, there was a question on azoospermia, that the vast difference block, but I'm not able to collect the complete question. So just please read semen analysis, azoospermia, and to find out the cause of azoospermia, FSH is being done, whether it is pituitary failure, gonadal failure, or there is obstruction at the level of vas difference. Then which is not seen in preterm baby? Normal genitalia, breastbud, Langerhans, Palmer crease. Genitalia is seen, sometimes there is an undescended testis. Langerhans is very well an important finding in preterm baby. Palmer crease is seen, but many times the breastbud is missing. So I would like to mark the answer as breastbud. So that's all.